Good afternoon, everybody. It's a privilege to join you today by video link for such a significant conference with such a timely theme. I can see from today's stellar cast list that you've already heard from real experts in public health as they consider the economic and social and, above all, moral imperatives to reduce health inequalities in England. But now the endurance test begins. You have to listen to a government minister for the next 15 minutes. Before I delve into the detail though, can I first pay a quick tribute to Jonathan McShane, our conference co-chair, who I know is standing down from local government in May. Jonathan, your contribution to the cause of public health in Hackney and more broadly through the LGA has been invaluable and you'll be hugely missed. Thank you for that, and I hope you'll stay involved in other ways, not least through your work as Chair of Trustees of the Terence Higgins Trust, where of course we've met before. Now today, I want to focus on three aspects of our public health strategy, which for the sake of clarity, I will call faith, flexibility and forward thinking. Faith in local authorities as they continue to demonstrate leadership, innovation and best practice in public health. Flexibility as financial pressures make demands on us all to work creatively together across sectors. And forward thinking, as we build on the success of national health strategies such as the tobacco plan, child obesity, and immunisation in preparation for the challenges that lie ahead. So let's explore matters of faith first. When in 2013, the government asked local authorities to take on a major public health role for the first time since the 1970s, we knew it was a big ask, but we already held the firm belief that you could and would deliver better outcomes for your communities, and that's exactly what you've shown you can do. As experts in the needs and issues of your local populations and democratically accountable to them, of course, who better to target services and support where they're needed most? Of course, public health practice, whether managed locally or from the centre, has made huge strides over the last century or so, transforming the living standards of millions and saving countless lives in the process. In many ways, I would say that progress has continued into more recent times. Rates of teenage pregnancy in the UK have almost halved in the past decade and are now at their lowest since record keeping began in 1938. Smoking rates in England are also at their lowest ever levels, down to 15.5% for adults and 7% for 15-year-olds. And last November, Public Health England published its annual elimination of HIV and HIV testing reports for 2017. They showed three tremendous firsts for the 30 years of the UK HIV epidemic. In London, all global United Nations HIV project targets have been met, with 90% of people living with HIV infection diagnosed, 97% of people diagnosed receiving treatment, and 97% of those receiving treatment virally suppressed. HIV transmission among gay and bisexual men has fallen, and the death rate among people with HIV who are diagnosed promptly and on treatment is now comparable to the rest of the population. So you and your predecessors from across the whole public health workforce should be very proud of your achievements. But that said, I'm sure you share my frustration that success in one patch is not always replicated and adapted in ways that reduce inequalities and health outcomes everywhere. There remains the persistent, pernicious and impersonal reality that where you live can adversely affect your health. Likewise, how much money you have and even your gender, ethnicity and orientation can still influence the way you and your physical and mental health needs are impacted and treated. That is quite simply wrong. I won't recite the facts and figures, you already know the nature and scale of what the Prime Minister recently called burning injustices. But our commitment to social justice and equality is why Jeremy Hunt and I now share a legal duty enshrined in the 2012 Act to work to reduce health inequalities. In fact, we've been consistent and bold in our ambition for public health in England. Ever since the 2010 White Paper, in fact, we will have succeeded only when we as a nation are living longer, healthier lives regardless of geography or economics. Now, history may tell us it's easier said than done, but that's the nature of a challenge, isn't it? Right now, we face a great deal of them, as you know, but I believe none are insurmountable, and that's down to the commitment and creativity of everyone working in public health. Now, I mentioned flexibility earlier. It may seem counterintuitive, but faced with tough fiscal constraints, there is an even greater need to be adaptive in our thinking. You're on the front line of the struggle. There's no denying that the 2015 spending review settlement for local government, including public health, didn't make things easier for you. Understatement. To be frank, it was tougher than I think most of us expected. It still requires a flexible and pragmatic approach. But while the LGA and the ADPH have raised their sincere and considered concerns about this, I have been unfailingly impressed by the magnificent commitment and resourcefulness local government is showing in responding to the challenges. And if I ever forget, Duncan Selby is there to remind me. Thank you, Duncan. Indeed, I've spoken before about the principle of self-sufficiency and devolution to the regions, so-called asset-based places where local authorities, health services and community networks work together to harness talents and resources on their doorstep. Let me illustrate what I mean. John Rouse, Chief Officer of the Greater Manchester Health and Social Care Partnership and a former Director General in the department, who I know well, recently talked about the benefits of what's known as the Wigan Deal. He said this: "The Wigan Deal is an agreement between the council and everyone who lives or works in the area. The council is committed to a series of pledges and in return asks residents and businesses to play their part too. Wigan has invested £7.5 million to grow social enterprises and community projects that reach the parts the council cannot. Over the last 5 years, they have reduced council budgets by over £100 million while still improving services and increasing resident and staff satisfaction. The time is right to grow the assets we all possess." End quote. I believe that applying this sort of approach to health and care provision can not only address inequalities, but clearly deliver social and fiscal benefits too. And talking of matters fiscal, the switch from ring-fence grant to business rate retention is scheduled for 2020. We in the department are working hard to make the transition a success. But I must caution you that this is not done and dusted. BRR represents real opportunities, but also some risks to funding for core health services, including but not restricted to substance misuse and sexual health. We're working closely and constructively on BRR with the Ministry of Housing, Communities and Local Government, but unless we're confident that those risks are being mitigated, business rate retention implementation for public health may be delayed. Now, of course, tackling the inequalities linked to economic deprivation is easier at times of economic growth that the BRR is designed to encourage. Local government is, I would say, exceptionally well placed to help deliver this health is wealth agenda. Think of the contribution it makes to making the best start in life, to improving our schools, our homes and the environment, and to local employment markets. None of us are in jobs because we want outcomes to deteriorate and inequalities to widen. So how can we get better at celebrating success and actually spreading, not just sharing and publicising good practice? Equally, how can the local government sector itself strengthen its support for those local authorities who have most trouble adapting to tighter budgets? And local public health activity is already far more transparent than it was under the NHS. But how can we really attract the attention of local communities to the issue? So while we are totally committed to maintaining and improving outcomes, we're genuinely open-minded about this sort of question. We're 5 years into the new system, and whatever happens about business rate retention, it makes sense to take stock now of what we could do better and differently without fixing a basic system architecture that frankly isn't broken. For example, I hope many of you will respond to our current call for evidence on the impact of regulations that require local authorities to take particular actions. Is a light touch approach the most effective? How can we refocus regulation on outcomes rather than just inputs? But I don't want to get totally hung up on funding issues today. There's a lot of ground to cover, certainly more than my allotted time allows. I know some people feared that a reduction in the size of the grant equaled a reduction in the government's interest in improving health and tackling inequalities. Well, I promise you that my interest hasn't declined, and those of you who've met me will know that, nor that of the Secretary of State, nor that of the Prime Minister, Theresa May. If anything, we're even more galvanised than ever to find new solutions, encouraged by the successes delivered by so many of you in this hall and beyond since 2013. So where should we look for inspiration as we consider future challenges and their potential solutions? Despite the progress I described a moment ago, smoking still represents one of the biggest single causes of inequality in life expectancy. So I'm proud that one of our first achievements after I took up my post in government was the publication of the long-awaited tobacco strategy. I really want to see more reductions in smoking rates in the population as a whole, but especially in the parts of the country where prevalence is highest, and among particular women in particular. Meanwhile, childhood obesity remains a huge challenge for all of us. We've made some huge leaps recently, but we've always been crystal clear that the plan marked the start of the conversation, not the end. The inequality gap in child obesity is widening. And while the plan delivers significant national population level policies, there is a need to really impact on child obesity and on this agenda at local level. A great example is the Wigan Let's Get Moving campaign, which aims to inspire healthy lifestyles for children and their families. Public Health England will shortly be publishing their report on sugar reduction, 1 year on. This has been a huge undertaking, and I pay thanks to Duncan and his team for the work they've done and will do on this. We know how many forward-thinking companies have risen to the challenge. I visited some of them, including Lucozade recently. But this will be an important point in which to judge progress in delivering our obesity plan and consider what further action we might need to put in place. These are all innovative and positive ways of tackling old, but what are very serious problems. I'm particularly interested in new solutions to another old problem, air quality. And when I say old, I mean really old. Burning coal was banned in London for being prejudicial to health in 1237. The evidence on this is clearer than the air we breathe. Air pollution has a significant impact on attributed deaths, and those with more limited means tend to live in areas where exposure to air pollution is greater. So we're working closely with DEFRA on the government's clean air strategy as part of our commitment to making this generation the first to leave our environment in a better state than the one we inherited. In July last year, this government announced £255 million for local councils to accelerate their air quality plans and has committed £3.5 billion overall to air quality and cleaner transport. To support the strategy, I've asked PHE to review the evidence for effective local interventions. This will give us solid, practical recommendations for improving air quality, prioritised according to local health and economic impacts. PHE's findings should be completed in August this year and will feed into DEFRA's work to cut negative health impacts from air pollution in half by 2030. I believe the clean air strategy can make a real difference to public health. Local authorities and directors of public health have important roles to play, and the Department of Health and Social Care is striving to give them the tools they need. But problems keep emerging, demanding alternative and new solutions. For example, the relationship between work and health, developments in immunisations and screening, and how we can prevent and address mental health problems. Those of you who know me well will be aware of my strong devotion to the cause of cancer prevention, and anything that promotes and improves early diagnosis gets my support every time. So here's an example of a great local solution from Essex. Here, some teams have developed bespoke awareness campaigns such as Females of the Future, while others share and implement best practice cervical screening guidelines for GPs, including endorsed patient text reminder services. More of this, please. And of course, the NHS remains a crucial delivery partner. There's still much to do to properly integrate planning and services. I sympathise with the frustrations I know many of you have about the limited local authority involvement in sustainability and transformation plans. I'm ready to fight your corner on this, and I am doing so please make sure the LGA and the ADPH know if you find yourselves running into a brick wall. This is something we must get right if we want to make a real impact on inequalities. Because even if we gave the NHS, say, to pluck a figure out of thin air, £350 million a week more, would that necessarily narrow the gaps in healthy life expectancy? Would it turn the tide on the obesity epidemic, on diabetes, or on the number of people who were first diagnosed with cancer in an A&E department? These are not burdens shared equally across our society, and we need to do more to understand and attack their root causes. For example, the Maternity Safety Transformation Plan. There's good news on reducing rates of infant mortality in recent years, but the rates are still too high, and inequalities are particularly significant. And seasonal childhood flu vaccine uptake is worse in schools in more deprived areas. Now, it's no secret that I wanted a ministerial public health brief in the Department of Health, despite, or maybe because of, the challenges it brings. So like you, I'm a volunteer in the fight against health inequalities, not a conscript. It's nearly 300 years since Benjamin Franklin observed that an ounce of prevention is worth a pound of cure. He was actually talking about fire safety, but if anything, he probably understated the case for preventing ill health. To you and me, Ben's argument just sounds like common sense, but we can't rely on it. The competition for resources isn't getting any less fierce. We all need to get better and smarter at making the case for our share of resources, nationally as well as locally, as strongly as we can. And locally is where the emphasis must lie, because as I said earlier, you are the experts in the health and well-being of the people you serve. You have a crucial role to play in shaping solutions to local problems and demographics. Together, we can overcome ignorance, prejudice and unjustifiable variation within communities to deliver public health services that benefit everyone, but also narrow the gaps. So finally, can I make a deal with you? Have faith in me to support you every step of the way, because I have faith in you. Thank you for listening, and enjoy the rest of your day.